Hello, this is Miss Turner, and today we're going to do a brief review of coronary artery disease and talk about coronary artery syndrome. Coronary artery disease is a type of blood vessel disorder that we consider in the general category of atherosclerosis. The term atherosclerosis comes from two Greek words, ather meaning fatty mush, and skleros, which means hard. This combination means that atherosclerosis begins as soft deposits of fat that harden with age. It can occur in any artery in the body. In the coronary arteries, the disease is called coronary atherosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, coronary heart disease, and other terms are used to describe coronary artery disease. They are often used interchangeably. Chronic stable angina refers to chest pain that occurs intermittently over a long period of time with a similar pattern of onset, duration, and intensity of symptoms. It can be provoked by physical exertion, stress, or emotional upset. This discomfort is often described as a squeezing, heavy, tight, or a suffocating sensation. It may be associated with other symptoms such as dyspnea or fatigue. Chronic angina pain usually does not change with positioning or breathing. An alternate type of angina is Prince-Meadows angina. It's a variant angina and it's rare. It often occurs at rest and not with increased physical demand. It's more commonly seen in people with a history of migraine headaches, Raynaud's phenomena, and heavy smoking. Strong contractions or spasms of smooth muscle in the coronary arteries result in increased intercellular calcium. The spasm may occur in the presence or absence of coronary artery disease. Factors contributing to coronary artery spasm include increased levels of certain substances like alcohol or cocaine, exposure to medications that narrow blood vessels, or cold weather exposure. Another angina variant is microvascular angina. It's chest pain that occurs in the absence of significant coronary artery disease or coronary patients. They have chest pain that's related to microcardial ischemia associated with atherosclerosis or spasm of the small distal vessels of the coronary microcirculation. Often this type of angina is brought on by physical exertion. Chronic stable angina can progress or develop into unstable angina or any changes in the usual pattern of angina should be evaluated. Until diagnostic studies and assessment is completed, it may be unclear if the patient's having typical chronic stable angina, unstable angina, or an MI. The overall goal for a patient who presents with angina include number 1, pain relief. 2, immediate and appropriate treatment. 3, preservation of heart muscle if an MI is suspected. 4, effective coping with illness-associated anxiety. 5, participation in a rehabilitation plan. And acute care for the patient with chronic stable angina is to position the patient upright unless contraindicated and add supplemental oxygen. Obtain vital signs and place the patient on continuous ECG monitoring. Obtain a 12-lead ECG. Provide prompt pain relief, first with nitroglycerin, followed by an IV opioid and analgesic if needed. Obtain cardiac biomarkers, assess heart and breath sounds, and obtain a chest x-ray. The patient may be anxious and may have pale, cool, clammy skin. Ask the patient to describe the pain and rate it on a scale of 0 to 10 before and after treatment to evaluate the effectiveness of the interventions. Assess for other signs of pain such as restlessness, ECG changes, high heart rate, respiratory rate, or BP, clutching at the bed linens, or other nonverbal cues. Support and reassure the patient's anxiety during an angina attack. For patients with refractory angina, enhanced external counterpulsation or EECP may be used. EECP consists of placing an inflated blood pressure cuff around the legs. The cuffs sequentially inflate during diastole and deflate during systole from the calves to the thighs. This action increases venous return and augments diastolic blood pressure. This increases coronary perfusion, improves left ventricular diastole filling, and helps the collateral circulation. EECP is contraindicated in patients with decompensated heart failure, severe peripheral artery disease, and severe aortic insufficiency. As previously mentioned, pain management is extremely important. Pain is the result of ischemia, so we do what we can to reduce the ischemia to the cardiac muscle, therefore reducing the pain. Initially, we do that with oxygen, and then we move to nitrates. We start with sublingual nitroglycerin. We give 1 to 2 tablets or metered sprays. We expect relief within 5 minutes, and that relief should last 30 to 40 minutes. We may repeat it every 5 minutes for up to 3 doses. If there is no relief, then we have to change our tactic. This is also what you're going to teach the patient when they go home. But what you're going to tell them is if there's no relief after 3 tablets or sprays, they should call EMS. Keep in mind that nitroglycerin can cause headaches, dizziness, flushing, hypotension. Be sure and teach the patient about these too, as well as proper use and storage. Sublingual nitroglycerin is a short-acting nitrate. Long-acting nitrates may also be used, especially to treat frequent angina or Prinzmetal's angina. The main side effects again are headache, orthostatic hypotension. These long-acting nitrates can be given orally, as like nitroglycerin as an ointment, or transdermal controlled release nitroglycerin. All right, so let's talk for a minute about some of the other drugs we use for stable and unstable angina, and we'll focus for a minute on our angiotensin converting enzyme, ACE inhibitors, and our angioreceptor blockers, or our ARBs. Patients with chronic stable angina who have ejection fractions less than 40, or diabetes, or hypertension, or chronic kidney disease should be taken ACE definitely, unless it's contraindicated. Patients with chronic stable angina and a normal ejection fraction, diabetes, and one other cardiac risk factor should also take an ACE inhibitor to decrease the risk of MI, stroke, or death. These drugs result in vasodilation and reduce blood volume. Most important, they prevent modeling in patients who've had an MI. For patients who are intolerant of ACE inhibitors, they have either that cough or that angioedema, angiotensin receptor blockers, or your ARBs, can also be used. Next up for discussion are our beta-adrenergic blockers, better known as beta blockers, and they're given for the relief of angina symptoms in patients with chronic stable angina. Patients who have left ventricular dysfunction or elevated blood pressure or had an MI should start and continue beta blockers indefinitely unless contraindicated. These drugs reduce myocardial contractility, systemic vascular resistance, and blood pressure, all of which reduce the myocardial oxygen demand and relieve angina symptoms. Beta blockers that reduce the risk of death in patients with left ventricular dysfunction, heart failure, or MI include corvidolol, metoprolol, and bisoprolol. Beta-1 receptors are found in the heart. Beta receptors are found in the blood vessels, lungs, and the liver. Some beta blockers are called cardioselective beta blockers because they only block beta-1 receptors. Some beta blockers referred to as non-selective beta blockers, and they block both B1 and B2 receptors. Beta blockers do have some side effects that can be poorly tolerated. These include bradycardia, hypotension, wheezing from bronchospasms, and GI effects. Many patients report weight gain, depression, fatigue, and sexual dysfunction. Absolute contraindications to using beta blockers include severe bradycardia and acute decompensated heart failure. Patients with blockers, especially the non-selective ones, they are used cautiously in patients with diabetes since they mask signs of hypoglycemia. Beta blockers should not be stopped abruptly without medical supervision, as this may result in an increase in the number and intensity of angina attacks. If beta blockers are contraindicated, are poorly tolerated, or don't control angina symptoms, then calcium channel blockers can be used. Their main effects are 1. Systemic vasodilation with decreased systemic vascular resistance, decreased myocardial contractility, coronary vasodilatation, and decreased heart rate. They're used to treat angina. There are 2 groups of calcium channel blockers. The dihydropyridines, such as amlodipine or nifedipine, have a more vasodilatory effect. The non-dihydropyridines, such as verapamil or daltiazine, have a greater effect on decreasing heart rate and contractility. Side effects include fatigue, headache, flushing, and peripheral edema. The non-dihydropines enhance the action of digoxin by increasing serum digoxin levels. Digoxin levels are closely monitored after starting these agents. Teach the patient the signs and symptoms of digtoxicity. Verapamil can cause severe constipation by relaxing the GI smooth muscles and slowing peristalsis, especially in older adults. So let's wrap this up by talking about the lipid-lowering drugs. A moderate or a high dose of a lipid-lowering drug is given unless contraindicated. Patients with chronic stable angina are encouraged to follow a diet low in saturated fat and cholesterol. When a patient describes new onset chest pain and coronary artery disease is suspected, or when a patient with chronic stable angina has a change in their anginal pattern, a variety of studies are done. After a detailed health history and a physical examination compared to a previous EKG to look for changes that might indicate acute coronary syndrome. Laboratory tests like acute cardiac biomarkers are also done to see if the patient is having an acute coronary syndrome. Other lab tests may be done, such as a lipid profile or a complete renal panel to identify risk for coronary artery disease. A chest X-ray is done to look for cardiac enlargement, aortic calcifications, and pulmonary congestion. An echocardiogram can detect resting left ventricular wall motion abnormalities, which might suggest coronary artery disease. If the EKG and cardiac biomarkers are negative, an exercise stress test with or without echocardiography or nuclear imaging may be done either during the hospitalization or as an outpatient. For patients with physical limitations in walking, a pharmacological or a dipyridinamole stress test with nuclear imaging or a pharmacological stress testing usually does not detect coronary blockages less than 70%. Besides stress testing, there are other tests that can be done if the EKG and cardiac biomarkers are negative. Electron beam computed tomography or coronary computed tomography angiography testing may be done if there is no evidence of coronary artery syndrome and the patient remains free of chest pain. There's a table in your textbook